All right, we're chapter 10, toxicology, hazmat, and WMD issues. Again, in our learning objectives, in an organized fashion, let's ID and treat any life threats along the way. In organized fashion, obtain an accurate history and perform an examination, and then to formulate the diagnosis. We're going to use this organization to then create a differential diagnosis list and refine that differential list along the way. So usually it's something that causes an overabundance can be toxic to our patients. Usually when they take some substance that in overabundance will manifest itself, its toxicity as this level gets high enough, the patient will present in some type of signs and symptoms, and that's our toxidrome that we're looking for. All right, so some of them we're looking at stimulants, narcotics, and pathomimetics. We can go over these, but you remember now, tachycardia, we have pinpoint people's respiratory depression. Again, stimulants and pathomimetics kind of regulate the same, so tachycardia, hypertension, jittery, and they may be speaking as fast as I am. Sedatives, less respiratory arrest, but a lot of respiratory depression, hypotension, cholinergic. We get the sludge them, and we would use the anti-cholinergic to treat them. That would be atropine. And the anti-cholinergic, we get the mad as a hatter, red as a bee, dry as a bone, all of those things. Right, so think about those as we go through. A lot of things with the toxidrome, it is the signs and symptoms that we're going to be looking for to take that and try to figure out what's going on. The autonomic nervous system uses the sympathetic nervous system, our fight or flight, alpha and betas, remember, and then parasympathetic to try to slow things down. And in some cases, if they're taking something at a toxic level, it may just blunt that entire response to it, blocks it from working. Okay, so initial approaches to these: safety, scene safety, and if it's an incident, we're looking to talk about initiating some type of incident command or incident management system as we go through this. Stage in the medical arena, as far as we're going here, we're a medical provider, so we're going to stage in there until we know that the scene is safe. We should be at least at the awareness level to identify that this could be a potential hazardous environment, and then figure out what kind of special needs do we're going to need: equipment, PPE, and facilities, right? And additional information that we're going to think about. Again, when we're setting up for these type of large incidents, this is large incidents. We're looking at creating some type of incident command system, and you as a medic are going to be placed in that medical event. In that medical event, we're looking at the MCI, so treatment, triage, and transport. And you are also there to maintain the medical establishment for the ongoing responders that are there to manage these events. So you're not only there to manage the patients that come from these events, but to provide safety and medical attention to all the providers that are there on scene. So case one, dispatched to a hotel, barricading his room and destroying everything there. We need some Leos, we need some hotel staff, we need other people that can apprehend or detain or at least control this, at least on scene, if this could escalate and get worse. We're screaming and wailing, lots of commotion coming from the room. This is not a scene that is safe. We need to get more information. We need to stage potentially and find out where the best place to stage. Now, it just may be a lot for show and not much is going on. So we want to kind of prepare ourselves to be flexible to go in any moment. All right, AMLS skill sheet to give us organized fashion. The scene probably not safe. We'll let law enforcement get there. They'll get into the room. Scuffle ensues. They pile on the floor and the person is wailing, incoherent. All right, so what is this? What's causing this? Right, is this drug related? Is this toxicity? Is this environmental? Is this metabolic? Is this AIU tips? Is this neurological, respiratory? What's causing this? They're saying it's excited delirium. The patient is unable to verbalize. It's just screaming. It's incoherent, combative, and fighting with us. He's awake. Eyes are glazed over, disoriented, breathing rapidly. Skin is flushed, hot and red, and this is presenting more like that excited delirium. We need to somehow treat this person definitely quickly, or else this person will end up going into cardiac arrest. This person is sick and we should move a little quicker and decide how we're going to get this person out. He needs to be medically cleared before you can say that this person needs to go under MH order or be put on a psych eval and go by other means. So we need to really start thinking about how we work with local LEOs and law enforcement to get our patients into the back of our medic to get them to the facility of choice. And what are our differentials now as we work up our patient? Could it be any one of these that we work on? And as we work through it, let's dive in and get our history of present illness. And some of us will be going again through our sample history, getting meds, allergies, and past medical history. And some of us might be doing some quick diagnostics and quick assessments. So the person just came into a adjoining room, just did not know that person, a guest, and it's 30 minutes now. Our sampler person has his colored pills and a crystalline substance, sea salt found on the desk. That could be something. Empty candy wrappers, history of psychiatric problems, and the law enforcement officers know this person. Well, this looks like it could be an issue where there is toxins involved. Heart rate's tacking away. Pulse ox is great. His breathing fast. Temperature is elevated. That's really high. Blood pressure is really high. Let's hope that this is it. He's working himself up. He's going to end up. That's the external temp. So we wonder the internal temp is going to get even hotter. Some quick assessments going on. Lungs are clear. He's just confused and disoriented. He's cooking himself down. Blood sugar 72. Doesn't necessarily mean that it's hypoglycemia. We might keep that in mind. 12 leads done. Sinus tach. No acute changes. They're going to do a urine. They're going to do troponin, lactate. These are all going to probably come back a little positive. We're going to get positive drug screen. We're going to get positive enzymes because it's going to go up and then it's going to come down. Hopefully if we can control this. But everything is going to be up on this. And there's our 12 lead. No acute changes. There may be some hypertrophy thing going on over here. I don't know if there's some electrical alternans, but there is a weird second complex on lead 3. Looks a little smaller than the rest, but other than that, it doesn't look like it's flowing. Our rate progression isn't the greatest, but we do have a tachycardia, and that person is very fast. What is our differential diagnosis now that we've gotten all of our assessment and treatment? Our assessment and history. Are we going with toxins and drugs, and what do we do for them? As we look to see, in the future of our call management, where do we go? What are we going to move our patients with? What is our BLS stance and treatment here? What is our ALS stance and treatment? What would be our critical care issues that we think about?